Paul, thanks for hopping on.
Zato, always good to see you. It's been a while, but it's nice to see you, and excited to talk about some of my favorite topics here.
Yeah, for sure. So, pretty much what we were talking about right before we hopped on, we're going to go over a lot of ACL. So, talk about prevention, rehab, thoughts and reasonings behind different ACL reconstruction. So, excited for the topic. But for those listeners that don't know you, why don't you give us a little background about you?
Sure. I grew up in the Carolinas, kind of just south of Asheville, and played football and soccer primarily in high school, and went to Wofford College to kick and punt under a coach named Mike Ayers, who Zato, you know very well. You're a little bit better at football than I was in college, but I always reassure my patients that I'm a much better surgeon than I ever was a kicker. So played 4 years there. We had some success, you could say. Went to the playoffs a few times and won a few championships. And then I went from there to Wake Forest for medical school, or Bowman Gray School of Medicine, for 4 years. Had a lot of success there and got interested in orthopedic surgery. Obviously, anybody that has a sporting background going into medicine has that in the back of their mind, I think, just because that's the physicians we most commonly interact with is otherwise healthy, 12 to 18-year-olds. And had wonderful mentors, a guy named Mike Freehill, who's now at Stanford, that was big into throwers, and injury prevention in the upper extremity. It was pretty impactful for me in medical school. And I ended up going to Washington University in St. Louis for my residency, which at the time and still now is kind of ranked, perennially top 2 or 3 residencies in the country for orthopedic surgery, and got absolutely phenomenal training and had great experiences there, holistically, specializing in sports medicine now. But when you're training, you really want to learn a little bit of everything. You want to learn how to treat trauma patients and hand patients and spine patients, because musculoskeletal pathology overlaps, right? Somebody
For
comes in with a
sure.
shoulder problem, it's actually their neck. Somebody comes in with a knee problem, it's actually their hip. So really need to be a generalist before you start subspecializing, and got excellent training in that at WashU. And now I'm a clinical fellow at the Hospital for Special Surgery in New York City. And I'm about 3 months into my fellowship now. So everything I'm going to say on this podcast is what I believe at this point in time. But I always joke that in some ways my approach to ACLs is something like the documentary Hero Dreams of Sushi, where all I think about is ACLs and knee injuries and sports surgery and how I can get better and how I can evolve. And I think it's important for a surgical practice, but especially as a trainee, having the chance to see how some of the best in the world do it, and take bits and pieces from each of them. So constantly thinking of how I can get better surgically and how to manage the patient more holistically, because you can do a perfect surgery, but if you do a bad job with your indications, or you do a bad job with your rehabilitation, your outcome's not going to be ideal. So I think just looking at it from start to finish, from the second you meet a patient to the second they get back on the field, how do you make them better?
Yeah, I think that's super important too, because like as a physical therapist, as a sports PT that sees a lot of ACLs, you don't really have too many conversations with the treating physician and the surgeon and things like that. So hopefully that's where we can take this conversation and kind of get your approach to surgical management and rehab with high level athletes, especially. So what does it look like when you first meet a patient after an ACL tear? What does that look like?
Sure. So I think I have, met a patient everywhere from on the sidelines of a high school football game to in the office with an MRI and a second opinion. So you see patients kind of all on that spectrum. I think for individuals, a lot of times they twist, feel a pop, immediately have pain, and they'll kind of give you the state they have the shifting sensation. They'll sometimes make a little motion with their hand that it's hard to see on a podcast, but they'll say, it feels like my knee just shifted. And so whenever I hear that, I think of really two things. ACL, very common, particularly non-contact, but you also have to be a little careful not to jump to that conclusion and think about, patellar subluxation or patellar instability as well. I think those two things can occasionally masquerade as each other, especially acutely. And then the nice part about seeing them on the sideline is their examination's reasonably reliable. So typically right after an injury happens, they don't have an effusion, they're not guarding, you can really get a nice Lockman or anterior drawer examination. And you can even pivot them a couple times. Once they figure out that sensation, they'll guard,
Yeah.
but you can really get an incredible exam right away. But there are some pearls to that we can get into. That's very, very different than the patient you're seeing in the office 4 or 5 days later with a tense hemarthrosis or a traumatic effusion that guards. They have an antalgic gait, they kind of have a quad avoidance gait, and they're going to be very hesitant to relax their hamstring, so you can really get a nice Lockman examination. So in that case, having that slam dunk physical examination for an ACL can be hindered by their guarding, but typically you can get a reliable Lockman examination and kind of suggest that's what's occurring.
Yeah, and I think that's interesting for at least my setting. I'm usually the first point of contact after any type of MSK injury working in the military. So, what are your pearls versus like determining ACL versus meniscus? So, a lot of our training talks about if you have acute swelling within the hour, it's more ACL versus, okay, they felt a shift or maybe a cutting mechanism of injury and it's just stiff. Then they wake up the next day and it's a lot more swollen and stiff. Maybe that's meniscus versus ACL.
Sure. Excellent point. So for me, isolated, especially posterior lateral joint line tenderness in about 90 degrees of flexion, so they're tender right on the joint line, that screams meniscus to me.
Mm-hmm.
I tend to do a relatively comprehensive examination at each point for the meniscus because so flexion compression testing, hyperflex the knee to 100, 110 degrees and internally, externally rotate, that tends to reproduce joint line tenderness. People will talk about a positive McMurray examination, which is, I think, the thing that most medical students experience. That's a painful, palpable pop. So that's very sensitive and specific for meniscal pathology. The problem is I find, at least for me and the surgeons I worked with, getting that palpable pop, unless you have a bucket, is not quite as reliable. So I tend to use the flexion compression testing, which is the same maneuver, but a different finding, I guess. And then Thessaly, so kind of have them stand on one leg, flex to 20 to 30 degrees and swivel their hips. That tends to be meniscus. And then a duck walk, or that's kind of hyperflexing their knee as well, but having them squat down like a duck and walk a few steps. If they complain of isolated joint line tenderness, that's meniscus more typically.
Yeah, no, that makes sense. I know a lot of our physical therapy clinical prediction rules like pain with end range extension, end range flexion, joint line tenderness, positive McMurray's, that's kind of leading us to more meniscus pathology. So no, that's definitely good to know.
You do have to be a little careful, I feel, because in the patient with an ACL injury, you'll see that they'll have an impaction fracture of their posterior lateral tibial plateau, and they'll have a bone bruise, and that's very evident on the MRI. If anybody's reviewed a lot of ACL MRIs, you can see that classic pivot shift bone bruise pattern. That hurts.
Yeah, for
That's
sure.
painful. You have a big bruise
Yeah.
there. So you have
Mm-hmm.
posterior lateral joint line tenderness from a bone bruise. So one thing I would caution, most, whether you're a trainee or even for me when I'm early in practice and probably throughout, is I've seen really, really good surgeons. I'm talking pro sports team physicians, world renowned surgeons, not be sure or, think it's, hey, I think this is an ACL, and it turns out it's something else. So when I talk to a patient, particularly on the sidelines, it's a very unique environment. If you're at an NFL practice, they are playing music with a DJ and 2 speakers, right? Take them somewhere quiet.
Mm-hmm.
Don't try to be a hero and say what it is on the sideline. Take them back to the training room, examine their knee and say, hey, I am concerned about your ACL, or I am concerned about the ligaments in your knee. Let's get an MRI and we can have a discussion, because first, your exam is not 100% specific, 100% sensitive, no matter how good you are, and you lose trust pretty immediately by saying, I think this is an ACL, and it turns out it's a PCL or something. You lose a lot of trust right away. And second, there's concurrent or concomitant pathology that might drastically change their management. So let's say they have an ACL with a bucketed meniscus. That can first block your Lockman examination because it prevents the tibia from coming forward, but also it changes your management. If I have a bucket handle meniscus, that is an indication to proceed to surgery without necessarily all the prehab that you'd normally expect. So from my standpoint, I generally say if somebody has a traumatic hemarthrosis or traumatic effusion, they're getting an MRI almost 100% of the time, except for maybe patellar subluxation or dislocation first time. Almost everybody's getting an MRI. And so the way I phrase it is, I'm concerned you have a serious injury within your knee. At this time, I can't tell you that your ACL is okay, and that's something that's certainly high on my list of concerns. Let's get an MRI and I'll call you and we can go from there. That's kind of how I like to address it, just to keep yourself out of sticky situations and lose trust.
Yeah, I like that. I really like that approach. So say you get the MRI, it's positive ACL pathology, and they come back. What do you tell them in regards to physical therapy, surgery, things of that nature?
Sure. So, and again, this is all evolving because I'll start my own practice next year at the University of Arkansas. And so I've given a lot of thought of how I'm going to do this, but this is just kind of what I've seen really good mentors do, that it's gone the right way. I'm going to try to see everybody twice before surgery. One, it lets you know I'm here for you, I'm available, and I'm in control of the situation, and I have a pretty standard approach, because you don't want to reinvent the wheel every time you do something. So the first visit, particularly once they get their MRI, pull up the MRI, let's look through it together. There's, generally speaking, a knee model in the room where you can go through. Most people have a general understanding of what an ACL is, what it does, and that it typically requires reconstruction, but not everybody. So I kind of give everybody the same spiel. Cruciate's Latin for cross. You have two ligaments that cross in the center of your knee. Anterior cruciate ligament allows you to cut and pivot, and yours appears to be torn on the MRI. And then we look through the MRI. And I say, these bow ties are your meniscus. They appear or do not appear to be intact. This in the middle is where your ACL should be. It appears that it's gone. And then you have a bone bruise here where your knee kind of shifted, and that's why you're feeling shifting when you walk. And then I tell them, typically, at this point, all they hear is wah, 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 wah. They just hear, I tore my ACL. Oh my gosh, am I ever going to play sports again? So you have an ACL tear. Before we talk about surgery and before we talk about what needs to be done, we have to get your range of motion back, because if we operated on your knee now, you'd be stiff going in, you'd be stiff coming out. I know you're uncomfortable. Let's get your swelling down. Let's get you into physical therapy and get your range of motion. And then I'll see you back in 2 weeks and we can discuss the details. So that's visit one. You have an ACL tear. You typically need it reconstructed, but you need therapy first. One. Visit two is where we really get down to the nitty gritty, and we talk about graft selection. We talk about expected rehabilitation, and then meniscal pathology, whether or not it's present. And then I kind of go over the brief details of surgery. On the day of surgery, you'll have a block. Surgery takes somewhere between an hour and 2 hours, depending on other pathology. We're going to use this graft for you. And here are the risks. So infection, arthropfibrosis, re-tear, and then patella fracture. Those are kind of the big risks that we go over. And then again, stop. That's all they need to know. This is surgery. This is what it's going to be. And these are the risks. And then do the surgery. And then we kind of go through their photos and talk about the rest of the course later on. But I think there's a lot to cover. And especially as orthopedic surgeons and physical therapists, we know a lot about the ACL, and it's one of our favorite things to talk about. So it's very easy to overwhelm the patient, I think, in my experience.
Yeah, definitely. And in between those first and second visits, you send them to therapy. What are you looking for? I know from my standpoint, I'm looking for full or as close to full knee extension as possible, like symmetrical to the other side, right?
Yep.
Knee
Correct.
flexion greater than 120, pending meniscus pathology, but we definitely want it to be as close to the contralateral side as possible. We call it a quiet knee, right? Like limited swelling, limited pain, good quad contraction, good gait pattern. And depending on how much time we have, some patients I have are back to squatting, lunging, things like that. They're just not doing the dynamic movements like sprinting, cutting, things of that nature.
No, I think that's an excellent explanation. And kind of my three is the effusion gone? Is the quad awake? And do they have full range of motion? And I think it's important, and as you've seen with your patient populations, especially younger females who are probably the highest rate of ACL tears, sometimes their normal range of motion is 5 degrees of hyperextension, which has implications on how I think about reconstruction. But also, just because somebody can get straight, if you have somebody that's used to 5 degrees of hyper on one side and they get straight on the other, they're not going to be particularly pleased with the range of
Hmm.
motion. They're going to say,
Yeah,
my knee feels stiff. For what's normal for us is not necessarily normal for them. So yeah, near symmetric to the other side. And I think, especially early in practice, I'm going to go a little bit slower with prehab, because I truly believe that the risk of arthrofibrosis is almost directly related to their preoperative range of motion and how quickly you get to surgery. And saving 7 days but costing a second surgery is probably, in my calculation, not particularly beneficial.
definitely. And when they come back for that second visit before surgery, how do you determine the type of graft that you use?
Yeah, so there is a overwhelming body of literature about graft selection. And I think there's a lot of surgeon preference based on training. And I think I probably have that as much as anyone. So first is auto versus allograft. And I think in my, future practice, the role for allograft in ACL reconstruction is incredibly limited. I mean, incredibly limited. I think that's not always the case everywhere in the country. A lot of people will say over 40 allograft. For me, we know from Chris Kading and the Moon Group and all of these large epidemiologic studies that the retear rate of an allograft is threefold or greater that of an autograft. So, and that's particularly in active individuals, which if you're doing an ACL reconstruction, the individual's active, right?
Hmm.
If you're not cutting and pivoting, you probably don't need your ACL. So for me, allograft is very, very limited, and maybe only in 50 to 60-year-old individuals that have failed non-operative care or conservative management for an ACL and are having instability with low demand activity. So turning corners or, just walking, their knees buckling. Those are individuals that maybe allograft is appropriate. But again, those are also the individuals that probably do okay with non-operative management. So for me, allograft isn't really part of my general algorithm. That's a very, very rare exception, I think. And then it comes down to BTB versus a soft tissue, whether that be quadriceps or hamstring. BTB is, I think, the gold standard graft. And the failure rate can be as low as 2.5%, depending on what patient population you're working at, what activities they want to go back to. But any level one sport, soccer, Australian rules football, handball, American football, any of those things, especially in the high school or collegiate athlete, is BTB autograft for me. And I think when you look at, players going on to the professional league and you're looking at free agents, that's what people expect to see. They expect to see a bone to bone autograft. And if you have something else, generally there's a question of why was that done? Not to say that the other grafts aren't good. It's just BTB is gold standard. It's tried and true. And I think for most people going to cutting and pivoting, that's the workhorse graft. And then soft tissue grafts. So quadriceps tendon autograft has really taken off as being a more popular graft option than hamstrings. And for me, I like that option a lot because it's reliable, meaning you can take a 9mm and 10mm in diameter graft, and that's about the size of your native ACL, somewhere around 10mm. Reliably in almost anyone, even in pediatric populations, you can get a 9mm graft out of the quad tendon. And it has the same biomechanical properties as your patellar tendon. It makes sense, right? It's similar function, similar origin insertion. It makes sense that they behave similarly. It is still a soft tissue graft. And I think my concerns with quad tendon graft are first that I think it might have some deleterious effects on the extensor mechanism. That's still kind of under consideration, how harmful is harvesting quad on the extensor mechanism. But I think those individuals have a little bit higher rate of arthrofibrosis, and I think it's because their quad takes a hit and they're having trouble obtaining terminal knee extension because they can't fire their quad. So little concern there. And then some people will use a bone block for their quad. For me, that defeats the purpose a little bit, right? One of the nice parts about the quad tendon autograft is that it's less painful than a BTB harvest. So I think you lose the benefit of that when you start taking some of the patella with it, but you don't necessarily have the gold standard graft of a BTB. So it's like the worst of both worlds. So for me, my graft algorithm is BTB for level 1 cutting and pivoting, high demand individuals and individuals that want to go back to skiing. In older patients, so like if I was going to do an ACL on me or you, 30, want to get back to jogging, maybe a little pick up basketball, not a lot. And maybe some skiing, but definitely not trying to go play college football anymore. I think quadriceps tendon's an excellent graft there. And then hamstrings for me is just a little bit more inconsistent, I think. Smaller petite females who might be an excellent graft option. Sometimes their hamstrings are smaller than 8 millimeters, and that really gets you into trouble about re-tear rates. So it is a good graft. I think in the right person's hands, it can be excellent, but BTB and quad are kind of going to be my workhorses, especially early in practice.
Yeah. I've been seeing a lot more quad grafts recently. And I don't know if you've seen this, but just anecdotally, it seems like it puts them about 2 months behind in regards to regaining their quad strength. Kind of like you talked about the extensor mechanism. I didn't have too many problems like getting their full knee extension, but their quad was just so weak afterwards.
Yeah, and I think especially, and this is like kind of a finer point, but on occasion, there's like a muscle, your VMO is kind of right next to it. And I don't know if it's just pain inhibition that's doing it, so it hurts, so they don't use it. Or if kind of like closing that defect pulls their VMO and kind of changes the vector. I'm not sure, but I completely agree with you that sometimes the quad, especially the VMO, takes a little bit bigger hit with quad tendon auto. That being said, I think you don't have the same anterior knee pain,
Hmm.
and you don't have the same risk of patellofemoral OA as far as we can tell with quad. So I think that is not in a college athlete where 2 months matters. I think it's absolutely something to consider, but in the recreational athlete or the older adult, I think it's still an excellent graft. But yeah, we're gonna find more shortcomings with the quad tendon autograft, I think, in the coming 10 years. It's just such a new graft, or relatively new in the terms of the history of orthopedics, that we haven't quite had those longer term outcome studies yet.
Yeah, definitely. I know there's a lot more research coming out about it in regards to rehab protocols and things of that nature. So moving on from that, what about meniscus repair during ACL reconstruction?
Sure. I think one of the areas where I've like personally grown in the last 2 years is understanding that, and I think sometimes you hear, oh, I had an ACL reconstruction meniscus repair, and you think that's all the same clinical picture, but there's a lot of difference
Yeah.
in what meniscus repair can mean. So first, not every ACL, this is going to sound crazy, but I think it's pretty well accepted in the orthopedics field. Not every meniscus tear with an ACL needs to be repaired, right? So if you have a small meniscus tear, I don't know, less than a centimeter, doesn't displace, stable on probing, you can just rasp the meniscus and let it heal. You don't need to put suture in that. So I think that's one consideration. That's almost like, yeah, there's a meniscus tear there, I rasped it, but this should not affect your rehabilitation. Same thing if it's a small meniscus tear that you have, one all inside suture in. I don't think that really changes your rehabilitation. I don't really think that changes your treatment a ton. That, and compared to like a longitudinal meniscus tear, where you can get reliable apposition of the meniscus. So that means for individuals that haven't done a ton of meniscus work, there's different morphology to your meniscus tear. So if it goes along the rim of the meniscus, like kind of parallel to the fibers, you can just put in sutures that grab it and squeeze it. And when you walk on your knee, it pushes the fibers together. That's incredibly beneficial, I think. So in that case, let them weight bear, because loading the meniscus is actually opposing the fibers and helping you repair. I think that's beneficial. We've become more in tune to Lamort tears, is what individuals will call them, or lateral meniscus oblique radial tears. And so those are kind of like diagonal tears in the back of the meniscus on the lateral side, which you want to repair because taking out the meniscus increases risk of arthritis. But weight bearing or loading that meniscus is not going to help it heal. It's actually going to stress the meniscus tear. And then you have, root tears, which have gotten increasingly popular in the last 5 years, where you're taking kind of the attachment of the meniscus and putting it back down to bone in a little socket. And those are incredibly friable. So those are very delicate, because you're basically grabbing wet tissue paper and trying to hold it in place for 8 weeks to let it heal. And every time you load your knee, it puts stress on that repair. So the short answer is it's complicated.
Yeah.
The long answer is some don't affect the rehab at all, and then some drastically dictate where you're going to do it rehab.
No, I mean, that was one of the most frustrating things for me early on when I was seeing high volume ACL and meniscus repairs because um, the protocols didn't really change. But when the patients would go back to see the surgeon, sometimes at 2 weeks, they could start weight bearing unrestricted. And then sometimes it'd be 6 weeks of restricted weight bearing. So it would just be all over the place. And I think that's where the PT and the surgeon have to be on the same page with regards to, okay, this is the type of meniscus repair we did. This is what I'm worried about in regards to flexion, range of motion, or weight bearing. So we can all be telling the patient the same thing.
Yeah, no, I completely agree. What's the best way in your experience for communication to work between the surgeon and the therapist? Is it as simple as a script? Is it a phone call? Is it a message? What is, from your perspective, the best way to have that communication?
Well, I think first off is just being able to read the op report, right? Having that in whatever medical record system that you have, just reading the op report and making sure that you know if the meniscus was repaired or not. That's the first thing. And then I've worked with some docs that specifically had the protocol in their notes, or they sent over the protocol with the patient in regards to what they wanted with weight bearing and knee flexion range of motion. But I've had the most success with just calling the surgeon or the care team and making sure that, hey, I'm seeing so and so. I know they had surgery 2 days ago. What were your thoughts on the meniscus? What do you want me to do and or stay away from? I think just having that conversation with the care team or the physician itself is the best way to go about it.
Yeah, no, that's a good point. And I think from my side of things, especially early in practice, that's my goal, is to just have the whole, I guess, city of Little Rock, Arkansas to have my phone number. Because as a surgeon too, sometimes your biggest fear is somebody going too fast,
Mhm.
and then showing up at your 6 week post-op visit with, oh yeah, I've been like with a root tear. Oh, I've been weight bearing, it's tolerated and whatever. So I think that really is the role for kind of the way I hope to set up seeing patients post-op, is to avoid some of that stuff. But yeah, I think being available from our standpoint is probably the most important part of making sure that what you hope is done is done.
Yeah, and another thing that we were doing at one of the places that I worked at was we were working with the surgeons as the PTs to make the protocol, because sometimes these protocols are 20 years old and the surgeon doesn't really know what protocol is being sent to physical therapy. But just all sitting down and having like a review board of, hey, this is the protocol for this, this, and this, so everyone's on the same page.
Yeah, and I think from my standpoint, I've done I've actually made a little bit of a concerted effort to look at my attending surgeons protocols and to steal them and download them. And I actually have a Google Drive with all of, not steal them, but look at them and copy them
Yeah.
for, but I mean, some of these things is, it's nice to get your input on, because you're an expert in this, right? You see
Mhm.
this all day, every day. It's all you think about, versus, all I think about is graft selection and screw fixation and where does this tunnel go. And so it's nice to definitely work together and have that relationship, I think.
Yeah. As long as there's guidelines, right? Or guide rails, just make sure that we're not going too far, too fast with things. PTs are generally smart, know how to work within those guide rails. But yeah, everyone needs to be on the same page, especially early on.
Yeah.
Um, so during the early rehab phase, like do you usually see them at like 2 weeks and 6 weeks? Is that something that you typically see?
So the way I'm gonna do things is copying one of my mentors, Matt Matava, who he's the head team doctor for the Blues and was with the St. Louis Rams for a long time, and he's been pretty impactful in the way I think about medicine and the way I think about orthopedic surgery. And he saw everybody at 2 days,
Okay.
so immediately, acutely after surgery. Um, Sit down with them, say, this is what your knee looks like. Can you go through the arthroscopic photos? I think that seems intimidating to people, but most people can tell that the big rope in the middle of your knee is your ACL, right? It's not
Hmm.
rocket science. We just make it harder than it needs to be. And we say, listen, this is your torn ACL. This is your meniscus. This is the meniscus tear, and this is how we repaired it. You see how it's nice and pushed together. That's why we're going to let you walk. And then we have a conversation about what to expect. And conversation 1, 2, and 3 is extension, extension, extension.
Yep,
So
for sure.
basically, that first post-op visit is to show them their X-rays. It's to show them their images from the surgery, and to talk about getting knee extension. That is absolutely by far and away the point of that visit. See them again at 2 weeks, and that's a wound healing check, really. I want to make sure, I want to see them fully extended, and I want them to be actively, I guess, perseverating about obtaining full extension. I'd like to see their quads start waking up. But really, the point of the 2-week visit is, are your wounds healed? Because BTB especially is a little bit bigger incision for sports surgery, and you want to make sure that you don't need to either redress a wound or do some kind of wound care. At that point, I'm going to be kind of, next goal is full range of motion. We want your range of motion excellent. We want your quad awake. And really harp on, this is the period where we need you to working on extension and working on obtaining full flexion while protecting your graft. So no open chain activities, don't go to the gym and do, leg extensions and put stress on your graft. And I'm playing with the idea of BFR at this point. I'd be interested to hear your thoughts. To me, it makes sense while you're protecting the graft to give the quad a little bit of help waking up. But I think BFR kind of comes into play once your wounds are healed. What do you think about that?
That's typically what I do. I wait till the 2-week mark. So once they get the stitches out and make sure that the swelling is down a little bit and incisions are healed, that's when we start BFR.
Yeah.
2 weeks until return to play.
Yeah. And then 6 weeks visit is your kind of next visit, range of motion. That's kind of the goal, range of motion. And then we kind of go into, as we were talking about, kind of the moon protocol, or kind of, it's more, a little bit more of a vanilla protocol, which I think is okay, but really focusing on first getting full motion back and then strengthening your quad and your hamstrings, with testing of strengthening starting at like 4 or 5 months ballpark, to say, not that I would never let anyone think about returning to play at that point, but just understanding their deficit in strength and then understanding what needs to be addressed. Is it increasing frequency of physical therapy? Is it maintaining the frequency? Is it maybe switching to once a week based on how their quad and hamstring function is progressing?
Yeah. So for me, full extension has to be there by 2 weeks. Full flexion should be pretty much symmetrical at 6 weeks. What about returning to like walking without crutches? Is that going to be your decision, or is that shared decision between you and PT?
So I think at 2 weeks is about when that starts happening. But at the 2-day visit or immediately post-op, what I'm going to tell them is, I don't want you, forcing yourself or toughing through it to walk off crutches. But when your quadriceps is awake, so my preference would be an adductor canal block instead of a femoral nerve block, which does play some role into shutting down the quad. A femoral nerve block will knock out your quad. An adductor canal block is distal to that, so more closer to the knee, so it won't. So once they can walk with a normal gait and their quadriceps function is returning and they feel comfortable doing it, I will tell them to walk around the house without crutches, and then they can leave the crutches for short distances outside the house and then all together. And if they're off crutches by 2 weeks, I'm absolutely fine with that. And I'm not a stickler. I just don't want people walking with an antalgic gait or a quad avoidance gait at the expense of getting rid of crutches. I think that is something that I'd be guarded against.
Yeah, for me, they need to be able to get full extension range of motion and 20 straight leg raises without any type of lag before they start transitioning from 2 crutches to 1 crutch to no crutches.
Yeah, and you say 2 weeks, is that a fair kind of, is that kind of your, what
Yeah,
you think?
2 to 4 weeks progress from 2 to 1 to 0 during that time period, as long as
Yeah.
everything's going well. What
And
about break? Oh, go ahead.
go ahead. No, braces.
Yeah, bracing.
None, unless you have a meniscus. So if you have a
Okay.
meniscus, I do want to prevent against hyperflexion. So even in meniscal repairs that warrant repair, meniscal tears that warrant repair, I'd like to avoid hyperflexion beyond 90 degrees. And I definitely don't want them loading the joint in flexion. So in that case, weight bearing is tolerated, knee brace locked in extension in most cases, but really don't flex beyond 90 for about 6 weeks, particularly with roots where you want to prevent against hyperflexion. But I think in the isolated ACL tear, there's enough literature to support that routine bracing is not efficacious and increases cost, that I don't think it's warranted. big caveat to that is a pediatric patient, because they're going
Mhm.
to do whatever they want.
Yeah,
So
they're
you're
going to
trying to,
school. If they don't have a brace, kids are going to think they're normal and they'll think they're normal and try to do too much.
yeah. So, I mean, I'm talking like under 12, under 13, you get a brace. And that's really
Yeah.
just to remind them that they're hurt, and it's a little bit of a seatbelt for them.
For me, I mean, don't let me tell you what to do, but high school kids, especially freshmen, sophomores, those kids will start trying to play basketball once they get off crutches. So it's a nightmare. I would not want to be dealing with all of that.
Yeah. I always tell them, especially around the 3 month mark, is when we have the conversation of the hard part physically is in some ways over.
Hmm.
You're feeling normal. Your knee starts to feel normal. You're ready to go, but biology does not care.
For
The
sure.
graft
Yeah.
takes time to heal. Your quad takes time to recover, and you're not ready yet. So I think that's something that you really start harping at really at the 3 month visit is, I know you feel good. Your knee feels fine. We've got to do everything we can to protect this, to make sure we do this one time right. I think is that when that conversation starts coming in.
Yeah. I like that a lot. All right. So let's get back into the topic of testing. Did you say that you typically do that at like 4 or 5 months? Is that right?
Yeah, I think, and that's something that I'm still playing with, honestly, as I look forward to setting up my own practice. It depends, I think, a little bit on how available testing is in your area. So, how easy it is to obtain an isokinetic strength test, and what battery is available to your with your go-to therapy location. So, I think a battery is important. I think a single metric, such as an isokinetic strength test, is useful. And that test in particular, I think, is necessary. But there's a whole lot of other aspects that go into return to play, including psychologic readiness.
Hmm.
So, kind of apprehension about returning to play, fear of re-injury scales. That's from the literature as important as your strength. So, um, my thoughts are you probably need some battery of both isokinetic strength testing, some kind of functional testing, whether that be, Y balance or something of that nature, and psychologic readiness to give you a holistic picture. And I think that should start by at least 6 months, just so you have an idea of, one, how close are they to being ready, and two, so you can trend it over time. Because I'm a little bit more encouraged as somebody whose isokinetic strength testing is going from, 60 to 70 to 80 to 90 than I am to somebody that's going like 65, 65, 70, 70, right? Those are two different conversations, and kind of way into your return to play. In your experience, kind of what batteries have you seen, and what batteries do you think are most useful from your perspective as a therapist?
Yeah. It all depends on the time in terms of how far they are from surgery, where they're at physically, mentally, and then what you have availability for. So I think starting at early on at that 4 month mark, you can definitely do isokinetic testing. And then Y balance. And then I have a couple other functional tests because at that point we're looking at returning to run at that 3, 4, 5 month mark. So for me, some type of quad strength test. So I want at least 70% limb symmetry index. For me, I don't have access to an isokinetic device, so I use a inline dynamometer just at 90 degrees, max volitional isometric contraction at 90 degrees of knee flexion, comparing it right versus left, and body weight. So their quad strength to body weight ratio is super important because in the literature they use a term like comparing two flat tires, right? So there's a detraining effect on their non-surgical side. So the athlete might have symmetry or close to symmetry, not 70%, but they might be weak on both sides. So that doesn't help at all either. So making sure that we're doing limb symmetry, quad to body weight ratio, and then I utilize Y balance, like you said. And then in regards to returning to running, I make sure they have good calf strength and endurance. So it's a pretty rudimentary test, but just like single leg heel raises, 20, 25 reps each side, making sure they have good neuromuscular control and good quad strength with like a 8 to 12 inch heel tap. So standing off the side of a box, doing like a single leg squat, tapping their heel to the ground, um, and making sure they can keep good limb alignment, no like valgus positioning, no trunk lean, and then just have good core control, right? So they can hold a side plank, good single leg balance, things of that nature.
Yeah, I think in an ideal world, especially with the elite athlete or the high level collegiate athlete, I also think this is a little bit where, as we get towards return to play, it's really nice to have some baseline testing, whether that's like a DARI functional screen or even GPS data from pre-injury for how much ground they're covering and their maximum velocity. I think is incredibly helpful for to tell people like, hey, either A, your maximum velocity and cut in distance covered in a practice when you're pre-injured was X and now it's half X, you're not ready. Or, hey, like sometimes it's the other conversation of your velocity is fantastic, you're covering as much ground, your functional screening is normal. Your body is behaving like it was pre-injury, even if psychologically, which is normal, you don't feel like that.
No, I mean, if I had access to GPS monitoring, like Catapult, I think the
Yep.
NFL uses a lot of Catapult
Yep.
data. Um, and then force plates. I'm sure you've seen force plates around the facility that you're at right now. Force plates are huge for the neuromuscular properties like power, things of that nature.
And I think this might be a good time to transition to like a lot of times we think return to play and physical therapy stops when they run out of 24 sessions or something, right? It's not like, I think that's something that as I get into practice, I'd like to help establish, and something that I think is a field we need to get better at is there's a difference between isokinetic strength testing being normal and you getting back into sport specific activities in a graded and responsible manner. It's not your isokinetic strength testing is better, go to soccer practice. It should be your isokinetic strength testing is better, you look like you're ready to start getting back into it, go to this performance center or physical therapy office that specializes in return to play, whatever, and start doing sport specific drills in a controlled manner, really working on neuromuscular training, I think is the ideal.
Yeah, because the strength testing is the minimum, right? That's kind of like the second tier of physical qualities. So you need power, rate of force development, speed. And I mean, some physical therapists, that's their realm as well. But just like you said, there needs to be some type of transition from thinking of it as physical therapy, but more of like training, right?
Yeah.
So at what point for you do you feel like, I know this is a rhetorical question, but like when you start your practice, at what point would you start considering, okay, let's start transitioning to more of that performance side of things?
I think that really, and I think that's a different, in some ways, conversation of than when you're ready to go back to play. I don't mean the same timeline for both,
Hmm.
but I think we can start doing kind of return to play like activities is around 7 months ish, depending on how their strength testing looking, return to play testing is looking. I will tell people for return to play 9 months is kind of depending on how they progress. I think that's normal. I think classically we used to quote 6. That's
Hmm.
too soon. And there's a lot of data that increases your re-tear rate, both ipsilateral and contralateral, which kind of do your two flat tires analogy. You've got to get both sides ready again because you've in some ways relieved your workload for 6 to 9 months. You need to build back up workload in a graduated fashion, I think.
For sure. Yeah, I tell people probably on the first or second visit, okay, this is going to be minimum 9 month deal.
Yep. Yep.
Expect a year.
There's a strong, there's a, I think he's a physical therapist named Paterno is his last name that does a lot
Hmm.
of return to play injury testing and second ACL rates. He has some really good, really convincing articles that we should be waiting a year or
Hmm.
more to get people
Yeah.
back to. You can make a very cogent argument that 2 years is the ideal return to sport after ACL, but in American culture and with American athletes, with a 4 year, we kind of think in 4 year cycles, right?
Hmm.
Collegiately, 4 years, high school, 4 years. I mean, in the pros, it's even with the financial part, even less sometimes. There's no way that from a cultural standpoint, that would be acceptable. But I think there is a cogent argument from a re-injury rate that that's maybe the safest, even if it's not practical.
Yeah. Tim Hewitt, he's a researcher. He promotes that 2 year, but it's the same thing. Like that's pretty much half of your high school or collegiate career. I don't think people will wait 2 years to return from an injury.
And I think from
Um,
my standpoint, one thing you have to be cognizant of is the way it sounds to the people you're treating when you go slow. And they think it's maybe potentially in some way a reflection of the quality of work. This person got back in 6 months. They must have had a better. And it's hard to make that argument to patients of your surgery went excellent. You did exactly what we needed to do. We are right on track. I understand that your friends may have gotten back to sports sooner than you, but I'm really trying to do the best thing for you long term. That's a tough conversation, I think. And it seems counterintuitive that maybe a more careful or thoughtful approach is a slower return to play.
Hmm. And that's where testing comes into play, right? Because if you have hard data to show them, hey, you're ready for this, but you're not ready for that, then they can actually see it and understand what's going on and why we're waiting or why we're not having them full return to play yet.
Yeah, for sure. The only hard part about that, again, is in an ideal world, I would test every month in an ideal world or every 6 to 8 weeks. But financially, that becomes somewhat burdensome on people. So if I only could test twice, it'd probably be 6 months and probably somewhere around 7.5, 8 months. But yeah, I think ideally you test them until they're back, and some people frankly never get there. And I think that's the role for a brace, a functional brace sometimes. But
Hmm. Yeah, I know the way that we practice right now, we test every month. Some of the tests may change, but starting at 4 months all the way into cleared, we test different qualities every month just to make sure that our program is effective.
yeah, I don't have quite as much experience with the military population. When do you see them going back? 9 months is typical return to full duty, or
Yeah, that's typically what we tell them, 9 months minimum. I mean, um, most jobs aren't as high, like cutting, pivoting, things like that in terms of like football or basketball, but they're still rucking or working with heavy loads, uneven surfaces, jumping in and out of trucks, things of that nature. So you still have to be more cautious with them. And then some
yeah,
of their military testing is like sled drag, sprints, shuffles, things like that. So they still have to be able to perform those activities.
yeah. I think, and that really, when you start looking at all the timelines we've discussed, probably no surgery for 28 days after injury is the safest thing to do to reduce re-injury rate or to reduce arthrofibrosis, and then no return to play to 9 months. It really is almost a full year from injury to return to sport. And I think that's something that people don't necessarily conceptualize is how difficult that is for a high school kid who we both in college kind of defined ourselves as like athletes, right? Like, hey, I'm Paul Inclan, I'm a kicker and a punter. Hey, I'm James Zotto, I'm a or are you academic All-American or an All-American safety?
Academic. I wish I was a real All-American. Just
But
academic.
that's how we introduced ourselves. So it's hard
Yeah,
when you take it, especially a collegiate athlete, away for a year. It doesn't matter that you're redshirting and you get a year back. Like it's tough.
for sure. For sure. Um, so when you start your own practice in Arkansas, are you going to be the gatekeeper for full clearance, or is that going to be something with you and the PT? Do you know how you're going to run that?
Yeah. So I think load the boat in some ways, I think is the right strategy for that. So I think it really does need to be a conversation because although I can see their Y balance numbers or isokinetic strength testing, you guys have a lot of insight as to their mental state. And hey, I know their Y balance looks normal, but they really look tentative. And I think that's a recipe for injury. So I think it's a phone call. And I think the third party in that phone call is really the athletic trainer. Um, because sometimes it means gradual return to play. Hey, this person's ready to go back, but they need 3 weeks before they compete. And they're the ones that are going to work with them every day to make sure that they're maintaining quadriceps strength and make sure that they're, starting with individual and then doing team and then doing contact. So I think it is between those three individuals. But I think I would like to have an office visit where we have that conversation of you're ready to go back to sport. That doesn't mean you're ready to play tomorrow night's football game. So I
Hmm.
think I'd like to be involved in that. But I think physical therapists in particular and the athletic trainer have insights into the finer details and maybe the things you can't pick up on a piece of paper.
For sure. And just something that I've seen that works well is, again, kind of like we talked about the protocol. So PTs, athletic trainers, surgeon, they all come together and determine what type of testing battery. And
Yeah.
then before they have that last visit with you, either the PT, athletic trainer, and both, they run them through that battery of tests. And then you get that battery of tests in the data sheet before they even see you. So you understand what they're coming in with.
Yeah, I think that's certainly the right way to do it. Is kind of like that team because I think you know your instinct is to want to be, especially early in practice. For me, it's like, oh, like I want to be the guy. I want to, be the expert. But I think recognizing your expertise and recognizing the athletic trainer's expertise is essential to getting them back successfully and safely.
Hmm. Is there anything else that you have on like return to play and testing batteries, things of that nature?
I think the only other portion that is really vital to discuss here is we need to start talking about the other knee, right? So when a player
Mhm.
starts coming back to sport, and ideally before they ever had their first ACL injury, now is when we talk about you have a BTB 2.5 to 5% risk of tearing this graft. You have double that risk on the contralateral side. So you have a 10% risk or 15% risk of tearing your other ACL. You're ready to go back to sport, but we need to keep you on a program so then a year you're not back in my office and we're restarting, because missing 1 year of a high school season or college season is tough. Missing two, that starts impacting your ability to play at the next level. That starts impacting your mental health. Like that is what we need to try to avoid. So I think as we talk about returning to sport, we also need to start talking about prevention if we hadn't done primary prevention with your team or something in the past.
Would you ever have, so say an athlete got cleared in like May and they're a football player, would you ever have them come in and test like later in the summer before the season starts, telling them, hey, I'm not going to hold you out, but I just want to make sure that we know where you're at?
I don't know if I've thought of it. I don't think it's a bad idea. I think I'm going to try to be very cognizant of collecting a lot of data, because
Hmm.
I don't think we can get better without data. And I don't think we can be objective about how we're doing and how our athletes are doing without data. So I'm certainly not opposed to that idea. I think it's probably more amenable in a collegiate population where maybe
Yeah.
cost is a concern, but not the same concern as, an out of pocket high school kid. Like, not as inconsequential, but I'd love the data. It's just how practically that can be done. I'm not sure.
Yeah, I don't see a lot of high school kids coming back in after being gone all summer right before the football season. They'll be done with it.
Yeah.
What about prevention programs? Do you have any thoughts on that?
Yeah, strong. Very strong
Yeah.
opinions on that. So that's one of the things that I mean, from a research standpoint, I think I've done everything from, arthrofibrosis after ACL, aspiration after ACL, revision ACL, ACL of NFL population. I mean, ACL is kind of my, I guess, favorite and in many ways only research topic. But I think currently I'm spending a lot of time thinking about ACL prevention and neuromuscular training in particular. So what that is breaking down functional movements. So landing, cutting, pivoting, those type of movements, breaking them down into essential components and focusing on form. And then that's combined with plyometric training and, agility training, et cetera. But it's really a focus on how the activity is being performed. And there's some studies that say it cuts down ACL injury rates. Meta-analysis would say 40 to 60%, especially in female athletes, and 70% of non-contact ACL injuries. So FIFA 11 is probably the most utilized. There's a FIFA 11 plus, there's a FIFA 11 plus kids. At the Hospital of Special Surgery, there's an app called Rips Wraps app that's really nice. It's like a web-based app. So I think the resources are plentiful. I think the majority of those resources are free or low cost. The hard part is implementing them and convincing people that they should utilize them when they feel fine, as with any
Hmm.
prevention program.
Yeah, and I think in the research, and a lot of people talk about instead of calling them prevention programs, calling them performance programs, because people will be more apt to actually go do a performance program instead of calling it a prevention program. Because, like you said, they feel like they're fine. They don't feel like they need any prevention. But if you call it performance, they're like, oh yeah, I want to get better at soccer or football, so I'll be more apt to do that.
Yeah, and the data is clear too that they do make performance better. So not only do they reduce injury rates, but they also make your linear velocity better. They make your Y balance test. They make your cone drill. They make all of those things faster. So I think there is a strong argument for that. The problem is coaches, in a lot of ways, are focused on, and they're incumbent to teach fundamentals in the sport, right? They want to teach how to kick a soccer ball, how to, you know, play soccer, what is the schematics that you need behind a sport. So they only have a limited amount of time, and the athletes, particularly high school athletes, only have a limited amount of time. And how do you ration that time in the most effective way? Because most ACL prevention programs need to be done 2 to 3 times a week for 20 minutes. So that's an hour. And if you've only got 4 or 5 hours of practice a week, that's a large chunk of practice taking out. So I think that's a challenge moving forward.
Yeah. And I mean, a lot of high school programs are getting strength conditioning inside, like that's their gym class, or they have a separate period for strength conditioning. So I think that's a really good start. So they don't have to take away from their time during practice and things of that nature. But for some like the club programs or schools that don't have strength conditioning coaches, I think that's huge because you can get better by playing a sport. But if you're missing physical qualities such as strength, power, things of that nature, you're never going to get that just from playing soccer or football.
Yeah, and there is some, this is kind of one of my areas of interest, but there is some thought and some data that would support that ACL injury preventions also increase the chances that a player moves on to the next level. So
Yeah.
this is more in like Europe where they have like their, Manchester United U15 team or something, but the chances they progress to the, premier team or the next level is actually higher if they have injury prevention. And I think it's a lot of ways because if you're missing a year, you're missing a year of development in that sport. So I think that's another way to frame it is, hey, if you want to make it to the next level, we need to prevent you from missing a significant amount of time related to ACL injuries or something of that nature.
Yeah. I think people will be a lot more apt to do that.
Yep.
Um, so I know that you're going to be going to Arkansas. Is that what, in 9 months to a year?
Yep. So I'll start, I believe my start date is October 1st. September 1st, for the University of Arkansas for the Medical Sciences, as a assistant professor in sports medicine there.
That's awesome. If you could build out a facility like a rehab or performance facility, what type of things would you want in there?
Oh man, now you're talking into like my dreams here.
Yeah.
So I think it needs to be billed as performance. So I think you're
Mhm.
spot on in that individuals are very hesitant to, or not hesitant, but maybe less likely to engage in activities if they think it's for injury prevention than if they understand that injury prevention and performance are synonymous. They're the same thing. I think for it to be attractive to the athlete, it needs to look what they're familiar with. So like a turf field or a grass field outside with lines painted and a weight room and things like that. And then the staff is probably more important than what the building looks like, right? So I think a physical therapist, particularly one that specializes in kind of, I refer to them as bridge programs, but the gap between a formal physical therapy session and return to sport, I think that's essential. And I think a strength and conditioning coach is also a big advocate there. And then finally, I think the part we don't talk about quite enough is if you can generate the volume for a sports psychologist. I think that's really important because hesitancy to return to sport a lot of times is related to the mental state, not necessarily the physical state. And then again, some of the higher level return to sport testing would be incredibly useful, I think, for a sports performance center. And I've used Dari in the past. That's kind of what I've seen, which is kind of 3D sensors without having to put dots all over people, and force plates, but something of that nature to really gauge how do we prevent injury? How do we get people to become explosive and biomechanically efficient after or before injury? And that really does take a team. And honestly, the least important or non-existent member of that team is probably the physician because everyone else has so much expertise in that realm.
Yeah. I mean, that sounds like a great facility. Hopefully you can get that rolling.
Yeah, donors coming soon, right? Let me know if you're
Yeah. Yeah, for sure. I
um,
like it. No, it's definitely nice to hear a doctor talk about performance and things of that nature because oftentimes when you have these conversations, they're not really thinking much past the initial surgery and a couple follow-ups. They're not thinking preventative, they're not thinking performance. So it's definitely refreshing to hear the way that you're coming about this.
and I think a lot of it has to do with as part of my fellowship, I get to learn from some of the incredible surgeons here, but also spend some time around the strength and conditioning staff and the athletic training staff of the New York Giants, which is incredible. I mean, the amount of, I guess, talent and thoughtfulness they put into every single aspect of taking care of the athletes incredible. And I think that's probably been a real area of interest and growth for me in the last few months, is just seeing how many incredibly talented people can assemble to really make sure athletes are getting the care they need to keep them healthy and let them perform.
Yeah, it's definitely great to hear. Hopefully that's happening across NFL, collegiate sports, even down to high school.
I think it's increasing across all levels right now. So
Yeah, yeah. Well, as we're finishing up, do you have any closing thoughts or remarks?
no, thanks for having me on. I think I've learned a fair amount from you as well, and it just really, I think, illustrates to me the utility of having a friend and a lot of colleagues that have a ton of expertise in physical therapy and all aspects, to see how you guys can make me look good, you know.
That's the goal, right? That's the goal.
Yeah. Everybody works together and makes each other look good, and the team works efficiently. So always good to see it, and I really appreciate you having me on.
No, I definitely appreciate it. If anyone wants to reach out to you or has any questions regarding your thoughts on ACL or any other sports performance topics, how can people reach you?
Yeah, my email is inclanpm41@gmail.com. So my last name pm41@gmail.com. Happy to have any emails. I will give the disclaimer that everything I think might change as I finish my training and start practice, but that's kind of part of growth, I think, is perseverating on how to get better. And I'd be interested to hear other people's thoughts of where we can get better, or where you think I might be wrong and should do a little bit more research or reading about how we can make, the perfect ACL.
Perfect. I'll make sure to link that in the show notes for anyone that's looking to reach out to Paul. Well, this is closing up. I appreciate it and definitely great to see you.
Awesome. Thanks, man. Always a
All
pleasure.
right.
Take care.
See you.